I'm Dr. David Santos, facial plastic surgeon, and we'd love to talk to you today about lower blepharoplasty. A good deal of individuals will benefit from it, and so everybody's different, and there's different presentations and different characteristics that would stimulate us to want to do rejuvenation of the lower eyelid. One of the easiest ways of doing it is for younger 20s and 30s and early 40-year-old patients, whereby we do a simple transconjunctival blepharoplasty. And again, what that is generally we'll do IV sedation or general anesthesia with supplemental local anesthesia. It takes about approximately an hour. So it's a lower transconjunctival incision, dissection down to the medial, middle, and lateral fat pockets, trimming, sculpting, and repositioning of the fat, releasing the arcus marginalis, repositioning the fat. And you generally don't need a suture, just let the incision heal on its own. Now, for the majority of our patients, but not all, we'll like to do some sort of tightening of the skin, and I like to do that with the best laser there is, I believe, the fractionated CO2 laser, whereby we can laser the lower eyelid skin. It tightens it up, helps with the skin appearance, helps with wrinkles, helps to tighten the lower eyelid, and is supplemental to rejuvenating the lower eyelid. There are instances where probably less than 5% of the time I'll do some other technique, depending on, particularly if there's aging to the lower eyelid, if the eyelid needs to be tightened up. There's pexes of the orbicularis oculi muscle or to the lateral canthal area, or even lateral canthoplasty, different types of techniques to tighten up the eyelid for individuals who are older and have aging to the lower eyelids and sagging of the eyelid itself, and what we call increased scleral show, where there's more part of the eye showing to the lower portion of the globe. Let's look at the anatomy of our lower blepharoplasty. Again, this is transconjunctival. So here we have a gentleman picture that's outlined. We have the bulging of the fat in this area here, but then we have this orbital line here, the demarcation line, and then the tear trough that goes down in this area. So we can see that in our patient, and so these are important aspects of the blepharoplasty. So what we did was contoured this fat, and we'll show you on this other picture, but we contoured this fat here, here, and here, the medial, middle, and lateral fat pockets, and trimmed them and sculpted them down. Now the incision was behind the eyelid. Now it's not on the skin here, it's behind the eyelid, whereby we address these areas. Now importantly, you have to release this arcus marginalis, which is this indentation right here. It has to be released in this area so that it elevates and helps us to treat that tear trough. And particularly we release from approximately here all the way to here on both sides. And this is a side view, and again, we're coming along in a transconjunctival manner. It's not an incision on the skin, it's an incision to the conjunctival here. This is the lateral view, and here's the orbit, and here's the lower eyelid. So we're coming along an incision through here as we go through the conjunctiva and the lower eyelid retractors. We're able to access fat pocket again in the medial, middle, and lateral regions. So we access this fat pocket, but we have to release this arcus marginalis, and in doing so, we've smoothed out this contour and improved this tear trough. And so you can see us releasing it from the bone in a subperiosteal fashion here, so as to release this. And now we have a fat that's been trimmed, but also has been repositioned over this region in the tear trough area, particularly here. And so again, so the incision's here, we release that arcus marginalis along the tear trough area here, across here, trim the fat, and then reposition the fat into this region here, which is right along the tear trough region. And so our patients generally will go home that same day. We'll see our patients the next day, make sure, just check on things, and then see our patients about a week later. Pain medications maybe for the first 24 hours, no more than 36 hours, and Tylenol, ibuprofen after that. We're back to social within 7 to 10 days, where things aren't really noticeable. Certainly by 14 days, we can get out and about in the real world, back to exertional activity after, say, 2 weeks, running, swimming, and lifting weights and so forth, as desired after 2 weeks.